and welcome everyone. Really happy to see all of you tune in to this really important topic we'll be discussing today. I hope everyone can see the screen okay. This is the agenda for today's session. Okay, I do see some nods, that's great. I'll go ahead and kick things off with a brief introduction about our host and the sponsor of this event. My name is April Godales. I'm the Managing Director and here representing for 24-hour home care. Sue Sexton is also on the call today representing for ONEgeneration. ONEgeneration is the host of this event, and I would like to take a moment to recognize them as they do very valuable work in our community. ONEgeneration is a 44-year-old nonprofit organization in the San Fernando Valley. They are committed to providing programs and services to older adults and their caregivers that help them keep them safe and protected. They have a senior enrichment center in Reseda, which just reopened to the public after being closed for 2 years due to the pandemic. They have an intergenerational daycare center in Van Nuys, which has an adult daycare and a child care preschool program, and it is also home to their Sunday Encino Farmers Market. ONEgeneration also provides care management programs for older adults in need, such as meal delivery and transportation to medical appointments. So thank you, ONEgeneration, for helping put this event together. Finally, to recognize the sponsor of this event, 24-Hour Home Care. I'm here representing on their behalf. 24-Hour Home Care is a non-medical home care agency specializing in sending qualified caregivers to assist with specifically activities of daily living in the comfort of our clients' homes. We pride ourselves in being a caregiving-centric company by offering an effortless experience to our clients and our caregivers with personalized caregiving matchmaking and with expertise our community can trust. And we're very honored to sponsor such an educational piece. I hope you all enjoy today's session and leave with many valuable takeaways. And with that, I will turn over the floor to Angela, who will introduce our speaker for today. Angela, the floor is yours. Thank you, everyone.
Hi, good afternoon, everyone. My name is Angela Suarez. I'm the Senior Manager of the Medical Network for the San Fernando Valley with Cedars-Sinai. For those of you that don't know, Cedars-Sinai is fairly new in the San Fernando Valley. We've been out here for about 3-4 years in quite some numbers. Today we'll be doing a talk with Dr. Esharaghi. He is one of the neurologists here on our staff and sees patients on a full-time basis in Tarzana. Dr. Esharaghi joined our staff maybe about 6 months ago and came from North Carolina. So I wanted to talk to you briefly before he gets started about some of our locations. As you can see throughout the San Fernando Valley and Conejo Valley, we have quite a few locations along with our recent partnership with Cedars-Sinai Providence Tarzana Hospital and as well as Huntington Hospital. So we have primary care services, laboratory services, cancer specialties, radiology, etc. And Dr. Esharaghi is one of the many specialists that we have here in the community that treat not only yourselves, but your patients. We have a list here of our physicians in the community that have what we call as greater availability. Those physicians on this slide should be able to see yourself or any of your patients within about 7 days for a new patient appointment or for a physical if needed. So without further ado, I will introduce Dr. Shervin Esharaghi. Dr. Esharaghi's specialty is neurology. He went to medical school at the Saba University School of Medicine. It is residency at the Medical College of Wisconsin, a fellowship at the University of Pittsburgh, and he can be found right on Ventura Boulevard to treat his patients. So here's some contact information here, and I will let Dr. Shervin Esharaghi take it from here.
Thank you very much, Angela, and thank you to ONEgeneration for inviting me to give this talk. Hopefully we can do it in a way where if anybody has any questions, you can even interrupt me. Feel free to interrupt me with your question, and we can discuss it as we go along. Otherwise, you can wait till the end if you'd like. So I'll be talking about stroke, and specifically more so with seizures related to stroke, because each topic is itself extremely wide, and I'm just touching the surface here. Stroke is the leading cause of disability in the United States, and it's the 5th leading cause of death in the United States. Number 1 is heart disease. Number 2 is cancer. Number 3 is accidents, actually, and number 4 is emphysema and lung disease. It used to be the 3rd leading cause of death, but we have really improved that significantly over the years. In terms of seizures, about 10% of patients who have strokes end up having seizures as a result of a stroke. Outside of that, we know that about 2% of the US population will get seizures, and about 10%, 1 in 10 people will have one time in their life a seizure. So there's many causes of seizures, but I'll be focusing more on actual stroke-related seizures, which comprise about 10% of stroke patients. Now, when patients have strokes, they typically have some sort of risk factor for stroke. Most common are high blood pressure, diabetes, high cholesterol or high triglycerides, which are lipids. They could be smokers. They could have some sort of inherited clotting disorders, such as factor V Leiden or other things that they inherit, and it causes their blood to clot more. Some patients have a PFO, which stands for patent foramen ovale. The foramen ovale is a hole in the heart between the right atrium and the left atrium. Babies have that inside the womb of their moms. And the reason for that hole is that they don't, blood that comes back into the baby's heart doesn't need to go to their lungs, because their lungs are not functional in the womb. The blood is already oxygenated from the mom. So the hole allows the blood to bypass the lungs of the baby and go straight to the baby's body. When we are born, that hole typically closes shortly after birth. But in about 25% of the population, it doesn't. That hole remains. And when that hole remains, it can cause stroke, because some patients can get clots in the legs that will break off, travel to the heart through that hole and into the arteries to the brain. So that is a possible cause of stroke in patients. And of course, the other common cause is atrial fibrillation. It's a condition where you have irregular heart rhythm. The atrium typically contracts uniformly to push the blood from the atrium into the ventricle. When it kind of fibrillates, which means a whole bunch of the ball just moves on its own without any rhyme or reason in a disorganized fashion, blood pools in the atrium, and that can lead to a clot forming, which then can later on go to the brain and cause stroke. So these are risk factors that we have to consider when someone presents with a stroke, as well as things we need to modify when we want to control their future risk. How do we go to the next? Okay, that's great. So I'll talk a little bit about the acute stroke treatment. So this is something that we have to educate the public about and the community about. There's been some major changes over the last 10 years. The important thing is that when someone is in the midst of having a stroke, time is brain. Every minute that you waste is damaging the brain further. And so we know that on average, about every minute, you lose 2 million nerve cells, neurons in the brain as the stroke continues. So you can imagine that when somebody has stroke symptoms and they call the EMS, by the time the EMS arrive and they take them to the hospital, they enter the ER, get evaluated, you know, you're already lost about 15 minutes of time at best. And that's about 30 million neurons you've lost already. Now, granted, we do have about 100 billion neurons in our brains, but we want to minimize that damage as much as possible. So the American Stroke Association came out with this mnemonic or acronym FAST to kind of remind people in the community that they need to react fast to stroke symptoms. The F stands for if you notice a facial droop or weakness. A stands for arm weakness, which can also just as easily be a leg weakness, or both. The S represents speech disturbances, inability to speak, inability to understand, confusion, and the T stands for time, in that time is of the essence. So remember the mnemonic FAST. You need to, as soon as you feel like there's some stroke symptoms, you need to call the EMS as soon as possible. So I'm just going to walk you through a little bit about what happens as you enter the hospital with stroke type symptoms. Once the ER physician or neurologist evaluates you and feels like your symptomatology and history is suggestive of stroke, the first thing that happens is a CT scan of your brain. CT scan typically is looking to make sure that you're not bleeding into the brain. The strokes that we're concerned about here at this point in time with our talk is our ischemic strokes. They represent about 85% of all strokes. 15% are hemorrhagic. That means there's bleeding into the brain. And that's a kind of a different animal that we're not going to touch on today. But the idea behind that CT is really to make sure there's no blood in the brain and that it's more consistent with the lack of blood flow, which is the ischemic strokes. Once we determine that, then we have to, we typically do a CT angiogram of the brain and neck, which looks at the blood vessels inside the brain and in the neck, taking blood into the brain. And we want to see if there's narrowing, if there's a tear of the wall or some other clot that's occluded a vessel. And we kind of take a look at that. And in some places where they have more advanced software, we look at CT perfusion, where we can actually determine an area of brain that's at risk and an area that has already died away, to see, how are we going to intervene. If we determine that this is an ischemic stroke and it is not due to any large blood vessel occlusion, but rather one of the tinier branches, and the patient presents to the hospital less than 3 hours since the onset of their symptoms, then they're likely to be a candidate to receive stroke treatment, which is the intravenous tissue plasminogen activator, which otherwise we can call it a TPA for short. Plasminogen is a molecule that's typically in our bloodstream. When it gets activated to plasmin, it breaks down clots, and it's part of the mechanism that keeps our body in regulation between clotting and not clotting. Well, here we've developed a drug that we can give that activates it faster and can break down the clot. And there are certain contraindications to giving that medication because it has risks of causing bleeding into the brain and elsewhere, including the gastrointestinal tract, which can be fatal. And about 6% of patients can get symptomatic hemorrhage in the brain from this. Patients who have had strokes in the last 3 months or have had severe traumatic brain injuries in the last 3 months cannot get this medication. Patients who have had a major surgery in the last 2 weeks cannot get this medication. Patients who have had any type of bleeding in the gastrointestinal tract or in the urinary tract over the last 3 weeks cannot get this. Patients who are on certain blood thinners like Coumadin, where the INR is elevated beyond 1.7, they can't get it. And then there's some other relative contraindications as well. If you have an aneurysm, for example, in your brain that's not been secured, or another abnormality in your brain, like a tumor or something, then we'd rather not give it in most cases because of the risk of bleeding. So once we determine that and those things are ruled out and you seem to be a good candidate for therapy, then we give you the drug, which is given initially in one as a bolus over as a quick bolus at the time, and then the rest of it, 90% is given over 1 hour. And the patient is then transferred to the intensive care unit where they are observed and watched carefully for signs of bleeding in the brain and elsewhere, and with serial neurological exams. The studies have shown that patients who receive this typically have about 30% chance of having a better outcome from their stroke versus not receiving it, relatively. That means they are more independent and have a better recovery 30% of the time. Now, I mentioned that this is mainly for patients who don't have large blood vessel occlusions. If there is a large blood vessel occlusion, intravenous TPA that I just mentioned is not as effective in breaking those clots up because they're usually very thick and difficult to do. So that's when a patient becomes more eligible for what we call mechanical thrombectomy. That means the interventionist goes into the vessels with a catheter and mechanically pulls the clot out of the vessel to restore blood flow. And that's actually extremely effective. Studies have shown that it can be very beneficial even up to 24 hours after the stroke onset. So we have a larger window for that. Now, going back to the IV, I said that typically it's less than 3 hours after onset, but we can extend that to 4.5 hours after onset if certain other things are excluded. For example, if someone's age is older than age 80, we may not want to do extended beyond 4.5 hours because there's increased risk of stroke, bleeding. If someone has, for example, diabetes history and a prior stroke, they have a higher risk of hemorrhage. So we may avoid giving it up to 4.5 hours. If somebody is on blood thinner like Coumadin, then we don't give it at all. So there are certain exceptions that are relative, but we can extend that window up to 4.5 hours if we need to. Of course, once the patient is stabilized, they come out of the ICU and then eventually end up in inpatient rehabilitation and then outpatient rehabilitation with physical therapy, occupational therapy, and they can still have improvement over the next 3 months, but usually plateaus at about 3 months after the stroke. If you could go to the next slide. So once the patient has had that treatment and is coming to the office for follow-up, we want to make sure, we want to try to reduce the risk of having another stroke. And so that's called secondary stroke prevention. And we employ various strategies. One thing, of course, is that we either initiate antiplatelet therapy like aspirin or Plavix or Agrinox, or we put them on a blood thinner like Coumadin or Eliquis or Xarelto, these things, depending on whether they have atrial fibrillation or not. Those things reduce the risk of stroke. Again, it doesn't make it zero, but it reduces the risk. Now, risk factor modification should occur. So if somebody has hypertension, we try to control the blood pressure tightly. If they have a diabetes, we try to control their diabetes much tighter with a goal A1C less than 7%. If they have high cholesterol, high triglycerides, we treat that. And there are certain goals that we have to reach for that as well, to reduce their cholesterol. If they're smokers, they need to quit. We give them ways to quit smoking, like Nicoderm patch or Nicoderm gum or other oral medications. And if they have a hole in the heart as the only risk factors, the patent foraminal valley that I mentioned, then we can consider closing that hole, and so to reduce the risk. If they have any kind of inherited blood clotting disorders, then we put them on blood thinners like Coumadin or Eliquis or Xarelto, things like that. And of course, for atrial fibrillation, the same anticoagulants that I just mentioned are also used to reduce the risk of stroke, because aspirin and Plavix and Agranox are not good enough to reduce the risk of stroke from atrial fibrillation. We need anticoagulation. Now, some patients, like I mentioned, about 10% may have seizures after the stroke, not necessarily in the immediate time, but 6 months later, etc. And we treat them with seizure medications. We don't usually use prophylactic medication. We don't treat preemptively, but if they have one seizure, then with a structural abnormality and damage to the brain from the stroke, then we do treat that with seizure medication. And of course, the patient may continue outpatient physical therapy, even speech therapy or occupational therapy if needed. So if you could go to the next slide. So who would benefit from seeing a neurologist? Of course, patients who are discharged from the hospital because of a stroke or seizure or both, for ongoing stroke risk factor modification, like I just mentioned. Some patients may need EEG, which is a electroencephalogram, looking at the brain activity to see if there's signs of seizure tendency or other seizures ongoing. The medications management for seizures. If they happen to have other neurological issues that are not related to their stroke or seizure, for example, they have numbness in the leg that is not stroke related, then they may need electrodiagnostic testing like EMG, which stands for electromyography and nerve conduction studies. Those things can be done as an outpatient to kind of clarify whether numbness is related to the brain or is it outside of the brain in the leg itself. And if you have some patients develop spasticity from stroke, so their arms and legs become really tight and stiff and difficult to move. That creates difficulty with activities of daily living, with dressing, with showering, with hygiene, and it can be very uncomfortable and painful too. Botox is a good treatment for that. We can inject the muscles in the arm or leg, and Botox allows that muscle to relax and reduces that spasticity, which is quite a relief for these patients. So that can be done. Some patients have swallowing difficulties after a stroke, which can lead to excessive salivation and difficulties swallowing their own saliva. Myobloc, which is similar to Botox, is a type botulinum toxin type B. It's a different type of botulinum toxin. That can be used to inject salivary glands to reduce the saliva formation and helps patients a lot with their activities of daily living. So these are just some indications that would suggest that seeing a neurologist post-hospitalization may be beneficial. Now, I think we have some questions here in the chat box, if I'm not mistaken. Let's see. Why are more younger people having strokes? Okay, you know, that's a good question. I don't necessarily know if they're having more or we're just recognizing more of them. But strokes in the young people can be related to several things. One is they could have that inherited blood clotting disorders that were just never identified before in their family, and they might be the first person that's having a manifestation of it. And there's multiple inherited clotting disorders. There's factor V Leiden, there's prothrombin gene mutation, there's antithrombin 3 mutation, there's fat protein C, protein S, homocysteine levels, a lot of other things that can do it. Also, young patients may be, by the nature of being more active, they're more at risk of having arterial dissections in the neck, where the arteries in the neck, the walls kind of tear basically from activity. And once it tears, clots form in the wall and can close off the vessel. That's common. In addition, we're beginning to realize more and more that this hole in the heart can be a cause of stroke in the younger people, the patent foraminal valley that I mentioned. As we're beginning to recognize that more, and we're closing these, we're seeing less of that. In addition, you have to also remember that sometimes they do an ultrasound of the heart through the chest, which is the more common way they do it in the hospital. You may miss that hole by doing that technique. So a lot of patients are discharged and they don't know that they have a hole because that particular procedure is not good enough to catch that. Transesophageal echocardiogram, where we go through the throat and look at the heart through ultrasound, that's more sensitive to picking up these holes. So we're picking up a lot of people that we didn't know had these holes in the past. That may be another reason for that. Okay, so the next question is, when my mother had her stroke, in her particular case, the CT only showed an old stroke rather than the active bleed she was having. Only after they did the MRI did they see the active bleed. Is it possible for an active bleed sometimes to be missed by CT as it did in my mother's case? Yes, it's not 100%. That is true, especially when it comes to, it's not so much the bleeding that occurs into the brain that's typically missed by CT, but the bleeding that may occur from let's say a small aneurysm or an AVM that ruptures, it can go into the subarachnoid space, and that can be missed about 10% of the time by a CT if you do it too early in the process. That's when we do a lumbar puncture to look at blood in the cerebral spinal fluid, because we may detect it there earlier and find it then. But that's not usually the case in terms of blood bleeding that occurs inside the brain directly in. It's less likely for that to occur. Is hypertension the biggest risk factor for stroke? Actually, it is. Among all the stroke risk factors, hypertension is the one that has the highest correlation to stroke, and the one that, if modified, lowers the risk tremendously. So it is one of the big ones that need to be controlled. What is the latest thinking on a daily low-dose aspirin for stroke and heart attack prevention, prophylactic protection, people with factor V or other genetic clotting disorders? This used to be automatically recommended, but sounding like there may be new thinking if someone hasn't had a stroke. Yes. So what you're referring to in terms of the aspirin is the difference between primary prevention and secondary prevention. So primary prevention of stroke is when nobody has had a stroke, and you're trying to put them on aspirin to prevent it from happening. This is no longer recommended. It was recommended in the past, but it's no longer recommended because studies have shown that the cumulative risk of hemorrhage bleeding from the aspirin
This week has gone by so fast, and I'm like, how are the words?
Is more than.
I'm sorry, excuse me. Can you just make sure that everyone other than Dr. Esharagi is on mute, please?
Yeah, so it's the cumulative risk of bleeding from the aspirin is more than the risk reduction in stroke. So it's no longer recommended for primary prevention. For secondary prevention, when someone's already had a stroke, it is recommended to be put on aspirin, assuming you were not on anything before you had the stroke. If you were on aspirin for some reason before you had the stroke, then that really constitutes an aspirin failure. And so that needs to be changed to something else like Plavix or some other thing. In terms of factor V or other genetic clotting disorders, again, there's no recommendation for aspirin. We really should anticoagulate those people with either warfarin or Eliquis or Xarelto to prevent future strokes. Okay, the next question is stroke risk as great with those with high blood pressure or diabetes if they're being controlled with medications? Well, no. I mean, if your blood pressure is well controlled and your diabetes is tightly controlled, then the risk of stroke goes down dramatically. So theoretically, I mean, you could have a risk of stroke as low as someone without those things, assuming your blood pressure is always controlled well and your diabetes always controlled well. Of course, the blood pressure goal is to be under 140/90 on a consistent basis, and the lower the better, up until 120/80, of course. And the diabetes, we want it under A1C, hemoglobin A1C under 7% on a consistent basis. That will definitely reduce the risk of future stroke. Okay, next question is CT angiogram relatively new in the past 20 years? Yes, it is. CT angiogram, I remember when I was a resident, it was not commonplace to do, it was just coming out. And so even the latter part of my residency, it was just beginning to come out. And then now it's more commonplace. It is much better visually to look at blood vessels in the neck and inside the brain with a CT angiogram. It has a better resolution. We can see things more accurately. In the past, we were using MR angiograms, magnetic resonance angiograms, like a part of an MRI machine. And you can see vessels there, but it's not as sensitive. It's not as accurate as a CT angiogram. So we may miss things with an MR angiogram. You can get a general feel, but you may not be able to get the details that you do with CT angiogram. Of course, sometimes we even do just an ultrasound of the carotids in the neck to look at, to see how tight they are. And that's okay as well, but it's not, again, it's not as good as a CT angiogram. That's more sensitive. That's probably the gold standard is a conventional angiogram where you inject dye into the veins and then take pictures of the neck and brain. That's the gold standard. CT angiogram comes very close to that, as close as possible to have like a conventional angiogram. And we shy away from conventional angiograms these days because it's more invasive. And it also requires, it also has a higher risk of possibly having a stroke during that procedure. So we shy away from that as much as possible if we can. Let's see, I think, are there any more questions? I would be happy to answer.
I'll just check through the questions really quick, Ashragi. So sure. No, I think that's it. I think we answered all the questions.
Thank you very much. I appreciate it. Thank you for the invitation. I appreciate it. And have a great day, everybody.
Thank you, everyone, for attending.
Thank you. Bye-bye.